Hi sir, good evening. This is Ravi. Just from Chennai. Sir, there is a audio error from your end. Yeah. Sir, there is a lot of audio crashing in your device. Sir, you request you to please disconnect the earphones or any headphones connected to the laptop. Sir. There is a lot of audio disturbance. Sir. Sir, please do not unmute. Sir, there is a issue with your mic. Sir, would request you to join from the mobile and put the volume of your laptop on zero. Sir, there is a lot of audio error. Sir, we are live, sir.
Sir, my screen is visible or not?
Yeah, your screen is visible, sir.
Sir, वो
Sir, we are live, sir.
ज्वाइन कर लीजिए, स्टार्ट करना। The doctor will join within 5 minutes.
Hello. Hello. Hello, sir.
Yes, sir.
Yeah, sir, we can expect the session to start, sir. Put the
Sir,
laptop volume on zero, please.
Dr. Ravi will join 5 minutes.
Okay, sir.
Yes, sir. तो हासिल बोल रहा था वो इसी में है ना। सर ये जो स्पीकर है ना आपकी इसी में। अच्छा, नहीं आप स्पीकर लेंगे सर, दिक्कत वो नहीं हो रहा है। ठीक। अरे 8 बज गया, दिख तो नहीं रहा।
Hi,
Good evening, sir.
good evening, good evening.
Can we start technical team?
Yeah.
Yeah, we are live, sir.
Good evening, team. Good evening, doctors. Here, Dr. Ravi Kumar Singh, a senior consultant nephrology and transplant at Max Super Specialty Hospital. He holds International Society of Nephrology ANO Basic Clinical Nephropathology Certificate and member of European Society of Nephrology. Also, doctors. So, here start, doctors. Can we start, sir?
Good evening, everyone. I'm Dr. Ravi Kumar Singh, and thank you so much for the giving me this opportunity. And today we are going to discuss a very important topic: cardio protection with GLP-1 analog uh, in high-risk patients. So next slide. Yeah. So this we can highlight with a case. The case one is a legacy patient with rising risk. This is a normal patient, Mr. Surendra, 66-year-old, with a BMI of 27, HbA1c of 7.2%, LDL cholesterol 68, and eGFR of 84. Current medications are metformin, glimepiride, atorvastatin, aspirin, empagliflozin, and telmisartan. He's a known diabetic, has a history of prior CABG, stage 1 hypertension, and cardiac echo showed ejection fraction of 55%. Next slide. So the guidelines recommend GLP-1 receptor agonist semaglutide. So ADA 2026, the pharmacotherapy of type 2 diabetes and associated comorbidities says that in patients, those who have a comorbidity, I think you can zoom this. I think use it in a slide sorter, then it will be very much, because it's a busy slide. We have to understand that in the patients who have atherosclerotic cardiovascular disease or they have indications of high CVD risk, GLP analog receptor agonist along with SGLT2 inhibitors are the first line of management. Similarly, in patients with heart failure, SGLT2 inhibitors are preferred, and in patients with CKD and those who have a higher BMI, GLP-1 agonists are given preference in the treatment. So they are now the first line of therapy. Next slide, please. Or if you will allow, I will share slides from my side also. I think that will be better. Next slide.
Once again, some technical glitch.
No problem, no problem. Please allow me to share my slides. I think that will be better. Is it visible? So this slide shows, hello,
Yes, sir.
my slides are visible?
Yes, sir.
Yeah. So this slide shows that in patients who have a very high atherosclerotic cardiovascular disease or they have a high indicators of high CVD or heart failure, SGLT2 is the first line, and we can add GLP-1 analog along with that. Similarly, in patients with CKD, SGLT2 have become first line therapy, and in those who have obesity or overweight, second agent that needs to be added is GLP-1 analog. So that is very important, and for weight management, I think they are the cornerstone, because with insulin, it is an anabolic hormone, so weight will increase. This is the beauty of these molecules, that they will cut down on the weight and also help in the retarding the progression of kidney disease. So next slide. The ADA 2026 obesity pharmacotherapy also says that in MASH, the benefits are demonstrated with semaglutide. Even with heart failure with preserved ejection fraction, semaglutide has shown benefit, and it reduces the heart failure events. Same with atherosclerotic cardiovascular disease, in patients with hypertension, in patients with diabetes, everywhere semaglutide has shown its benefit. So it's a wonderful molecule for cardio kidney metabolic syndrome. So the AACE 2025 guidelines shows that in cardio metabolic syndrome, if the patient has pre-diabetes or metabolic syndrome, diabetes prevention, then semaglutide has an upper hand. Same in patients with type 2 diabetes, for MASH, for heart failure with preserved ejection fraction, chronic kidney disease, or in hypertension. Everywhere, semaglutide is a molecule that can be used. Even in osteoarthritis, it helps in prevention of osteoarthritis, and it also helps in obstructive sleep apnea. So the European Association for the Study of Obesity, the guideline says that we should, the core intervention is lifestyle modification, and then according to the comorbidities, we have to use semaglutide or other therapies. The ACC, AHA, and ESC and ADA summaries of the guidelines recommendations for GLP-1 receptor agonist use. So all the major guidelines have given almost class 1 or class 2A of the recommendation for this class of molecules, and all these studies have been with semaglutide. So it has a very robust data supporting its use. So the SELECT trial was a semaglutide and cardiovascular outcome in patients with overweight and obesity. The mean follow-up was 39.8 months. It is the once weekly subcutaneous semaglutide, and endpoints of cardiovascular death, non-fatal MI, or fatal stroke. This shows, in this trial, it shows 20% reduction in the risk of MACE and 15% reduction in risk of death from cardiovascular causes. Even in secondary endpoint, it shows almost 10% body weight loss and 3.8 millimeter of mercury drop in blood pressure, systolic blood pressure. So it is associated with a lower risk of cardiovascular events compared with tirzepatide in patients with overweight or obesity and atherosclerotic cardiovascular disease, and without diabetes in routine clinical practice. So this is the STEER study results, where it was compared head-to-head with tirzepatide. So this study concluded that overweight or obesity and ASCVD, but without diabetes, there is a lower risk of CV events with semaglutide compared with tirzepatide. And there is significantly lower risk of revised 3-point MACE with semaglutide versus tirzepatide. So in this legacy patient with rising risk,
अरे बड़े हैं डॉक्टर ज्वाइन किए हैं
hello,
ठीक
hello, am I audible?
यस सर
Yeah. So questions are, what are the key clinical factors that would drive your decision to initiate GLP-1 analog receptor agonist in this patient? Considering the patient's current medication regimen post CABG that offers CV benefit, how do you assess the additional CV advantage of GLP-1 analog receptor agonist compared to the existing regimen? And if the patient had been on a GLP-1 receptor agonist today and was to have CABG today, how would you handle the patient's care in both the preoperative and postoperative stages? And what parameters would you prioritize while using GLP-1 in this patient? And how would you define treatment success in this patient? So, overweight patients with severe risk. Let's say case 2 is Miss Lobo, 52-year-old homemaker, HbA1c 6.6. The BMI of 27.7, LDL 110, and triglyceride 180. So even the ADA 2026 obesity pharmacotherapy shows that semaglutide can be used across the board. So the algorithm is, and we have to tailor the therapies for the comorbidities. In type 2 diabetes or cardiovascular disease, semaglutide is the preferred therapy. The best evidence, and it is superior for cardiovascular disease reduction. The 2024 ESC guidelines for the management of chronic coronary syndrome, it also says, gives it a class 1 recommendation for SGLT2 inhibitors and class 2A for GLP-1 receptor agonist. So the only anti-obesity drug approved by the ESC guidelines for chronic coronary syndrome without diabetes with overweight or obesity on the basis of SELECT trials. So SELECT trial was a semaglutide and cardiovascular outcome in patients with overweight and obesity. Second case is overweight with severe risk. When the patient is overweight and has no ASCVD yet, but her risk factors are stacking up and lifestyle modification have failed. I think in these patients, it's very useful to use the GLP-1 receptor agonist for the optimal management of these patients. Thank you. Ashish?
Sir, we have one question.
Yeah.
Sir, question is, sir, how should semaglutide be titrated to minimize GI side effects?
So the very good way of doing it is give it 1 hour prior to giving any food. Keep a interval of 1 hour in between taking any food. And if someone has some nausea or some vomiting tendency, it's better to take something like mint flavored juice or lemon flavored juice to be taken half an hour after the semaglutide. So what will happen? It will mitigate the effect and the nausea will certainly come down. And I think it's always a good idea to do some brisk walking after taking this molecule, because that will help in this gastroparesis, and there will be less incidence of peptic ulcer disease or nausea and vomiting. So in this way, we can mitigate the risk.
Thank you, sir. Sir, one question more. How should patient be switched from another GLP-1 receptor agonist to semaglutide?
Yeah, so The good part with semaglutide is it's a once weekly therapy. So suppose some patient was taking some other therapy like dulaglutide or liraglutide. So you can just skip their dose, and from next day onwards, we can switch to semaglutide, and then we can continue the weekly therapy of semaglutide. So there is no issue.
Thanks.
But whenever we start the patients at the lowest dose of 0.25.
Okay, sir. Thank you, sir. No more questions.
Okay, Chief. Bye-bye.
Thank you so much, Doctor.
Thank you so much,
Thank you.
Victim. Thank you.
Hello, technical team. Hello, technical team. Hello, tech team.
Hello, sir.
Yes, ma'am. Hello, technical team.
Yes, sir. Did you call?
We can close.
Yes, sir. Yes, sir. We can end. Thank you.
Thank you.